All right, everyone, it's the top of the hour. I'm Dia Wagasback in Houston, Texas. I want to welcome everyone to today's GlomCon. Today, we are excited to have back our series in collaboration between GlomCon and the European Renal Association and JOVSEN. And with that, I'm going to turn it over to Dr. Kate Stevens, a consultant nephrologist at Queen Elizabeth University Hospital in Glasgow, to introduce our talk and speakers.
Thanks, Dia. So welcome everybody. So today's European Renal Association session is in conjunction with the Spanish Young Nephrologist Society. And we have to give thanks to our man behind the scenes, Marco Montemoli, who coordinates the Spanish Young Nephrologists. He has put together the speaker and the panel today. So thank you, Marco. So our speaker is Dr. Fernando Caraveccia Fontan from Madrid. And we've got a fantastic panel, a nice balance of women as well, which is great to see. So we have Dr. Elena Gocoechea de Jorge, who's an immunologist, and Manolo Prado, who's Professor of Nephrology, and they are both also from Madrid, along with Fernando. We then have Prof. Molier Le Quintrec Donnet, who's Head of Nephrology from Montpellier in France, and Dr. Anuja Java, who is Director of Kidney Transplant at the John Cochrane Medical Center in St. Louis in America. So I'll hand you over now to Fernando.
Okay, so hello to everyone. Well, it's a great honor for me to participate in the GlomCon online meeting. And so I really appreciate this invitation. And so today I will do a general update on C3 glomerulopathy, and we'll also comment on the papers that our group has recently published. The complement system is one of the most important elements of innate immunity and has a very relevant role in the defense of the organism against pathogens before an adaptive response is elaborated, and also has an important role in the removal of immune complexes or cellular debris. As you all know, the complement system is formed by a set of plasma molecules that interact in different biochemical cascades, distinguishing three main activation pathways: the classical, the lectin, and the alternative pathway, which converge in a common activation pathway and ultimately form the so-called membrane attack complex that causes pores on the cell surface, leading to its lysis. The alternative complement pathway is continuously active following a takeover process. C3 is the central molecule of the alternative complement pathway, and its spontaneous activation is the characteristic feature. Thus, in order to prevent the alternative complement pathway from damaging the own structures, there's a wide variety of factors that regulate its activity, both in plasma phase and at cell membranes, which are represented in this slide. This regulation of the complement system can induce or promote the development of diseases at different levels, and in recent years, the complement system has been involved in the pathogenesis of a wide variety of diseases, as shown in this slide. And although complement activation has been implicated in the pathogenesis of diseases such as IgA nephropathy or ANCA-vasculitis, for example, the two main entities resulting from complement dysregulation are hemolytic uremic syndrome and C3 glomerulopathy. C3 glomerulopathy is a clinical pathological entity secondary to the dysregulation of the alternative complement pathway in plasma and the glomerular microenvironment, leading to a predominant deposition of the C3 molecule and its degradation fragments that will be detectable in the kidney biopsy. Two main subgroups are distinguished, the so-called C3 glomerulonephritis and dense deposit disease, which actually have overlapping clinical and pathological features. Overall, C3 glomerulopathy is a rare entity with an estimated incidence between 1 to 3 cases per million population, with no significant difference in America or Europe. And although the pathogenic mechanisms are not fully understood, the basis of the disease is a dysregulation of the alternative complement pathway, which could be genetic or acquired. Among the genetic causes, according to published studies, we would find variants in complement genes in about 25% of the cases, and these variants would be in the genes of C3, factor B, factor H, factor I, or factor H related proteins. On the other hand, acquired factors may be responsible for the disease in an estimated percentage between 25 to 50%, and may be mainly the so-called C3 nephritic factors, with the ability to stabilize the C3 convertase, prolonging its activity and leading to a massive serum consumption of C3. In addition, monoclonal proteins could act as nephritic factors, stabilizing the C3 convertases, or by acting as autoantibodies against complement components. And even though the pathogenic mechanisms have not been fully deciphered, there is a consensus to consider them as a distinct subtype. Either way, complement activation ultimately leads to an accumulation of complement molecules and degradation fragments within the glomerular microenvironment, causing damage both to the endothelium and the podocytes through the mechanisms described in this slide, and ultimately result in inflammation and cellular proliferation. A kidney biopsy is required for the diagnosis of C3G, and the current consensus definition relies on the presence of a positive glomerular immunofluorescence staining for C3, either isolated or at least 2 orders of magnitude greater than the rest of immune reactants. And as with other glomerular diseases, kidney biopsy at the time of clinical diagnosis has an important implication. In this study by the Columbia University group, the authors proposed a histopathologic index to analyze both activity and chronicity parameters in the kidney biopsy of patients with C3G. The different histologic parameters studied are shown in this slide, and the lesions were scored as 0 to 3, except for atherosclerosis that were scored as 0 to 1. In this study, the authors found that both the total activity and chronicity scores were independent predictors of kidney outcomes. So addressing at this moment the potential therapeutic alternatives in C3G, unfortunately, no target therapies are currently available in clinical settings for the treatment of the disease, although several new molecules are under investigation. And thus, the therapeutic alternatives available at present can be classified as supportive therapy, conventional immunosuppression, and anti-complement therapy. Our group published in 2015 a pioneer study which collected a fairly large cohort of patients with C3 glomerulonephritis, and for the first time showed the therapeutic benefit of the immunosuppressive regimen based on corticosteroids plus MMF. This was a retrospective observational study with 60 patients, and we collected the type of immunosuppressive therapy that patients had received during their follow-up. As you can see, 22 patients received corticosteroids plus MMF, 18 patients received corticosteroids plus minus cyclophosphamide, whereas 20 patients received no immunosuppressive therapy. At last follow-up, a significantly higher kidney survival was observed in patients treated with corticosteroids plus MMF as compared to the other immunosuppressive regimens. In addition, the results from genetic studies further suggested that this therapeutic benefit would be more important in those patients with antibodies against complement components, although only a small percentage of patients had genetic and molecular study performed, and this is why a new study would be necessary to further analyze this hypothesis. The next drug to discuss is Eculizumab, which, as you all know, is a monoclonal antibody that prevents the cleavage of C5 molecule and thus inhibit the complement terminal pathway. And this is the only anti-complement therapy available in clinical settings currently. Different studies have analyzed the potential therapeutic benefit of Eculizumab in C3G, although the results were not as good as expected. Probably it's an expression of the high heterogeneity of the disease. Thus, Eculizumab is mainly used in cases of C3 glomerulopathy with an aggressive clinical course. And these are two very important papers that analyze the clinical profile of patients that could benefit from this therapy. So I really recommend you to read these great and important papers. Another recent study analyzed the therapeutic effects of Eculizumab on proteinuria in patients with membranous proliferative glomerulonephritis, including both C3G and immune complex MPGN. This was a prospective phase 2 study with an off-on design, and Eculizumab was administered for 48 weeks, separated by a washout period of 12 weeks. 10 patients were included with nephrotic range proteinuria and high level of C5d29. And the results were as follows. In 3 out of 10 patients, treatment with Eculizumab was associated with a significant decrease in proteinuria. In 7 out of 10, In 7 out of 10 patients, treatment with eculizumab had no significant effect on proteinuria, and 1 patient progressed to end-stage kidney disease. The authors also found that the presence of C3nF was associated with a lower probability of response to eculizumab. Fortunately, a great number of newer complement blockers are under investigation in clinical trials, and thus it is likely that in the coming years, the range of therapeutic alternatives will be greater, and so we will be able to personalize treatment according to the underlying pathogenic mechanism involved. In fact, in last year's ASN Kidney Week, some promising results were presented using a complement factor B inhibitor called LMP-023 and another C3 inhibitor called pegcetacoplan. So yeah, we really hope we can have more data in the coming years. Over the last few years, our group has continued to work on C3 glomerulopathy, and as a result of a nationwide research initiative, we have published some new papers on this matter, and we will summarize this result in the following slides. The first study was published in Clinical JOVSEN and was entitled Mycophenolate Mofetil in C3 glomerulopathy and Pathogenic Drivers of the Disease. The main objectives of this article were to confirm in a larger cohort of patients whether the therapeutic regimen based on corticosteroids plus MMF was beneficial, and to analyze the clinical and genetic profile of patients that could benefit from this regimen. So this was a retrospective study in 35 hospitals from Spain, and we collected all cases of C3G according to immunofluorescence criteria from 1995 up to today. And as you can see in this flowchart, the study group consisted of 97 patients after excluding 17 cases with concomitant monoclonal gammopathy. The mean age of the study group was 32 plus minus 21 years, being 54% of the cases males, and the majority were adults. 84% corresponded to C3 glomerulonephritis as compared to dense deposit disease, which were only 16%. All cases had a complement molecular genetic analysis performed, and as you can see in this slide, 18 patients had pathogenic variants in complement genes, mainly in complement factor H, complement factor I, C3, complement factor B, or complement factor H related. 58 patients had variants of unknown significance, and in 42 cases, the variants were considered as benign. On the other hand, 30% had antibodies against complement components, and the majority of them were C3 nephritic factors as compared to anti-factor H. In this slide, we summarize the different therapeutic alternatives received, and of note, 17 patients never received immunosuppressive therapy at the discretion of the treating physician, 13% received corticosteroids, 42% received corticosteroids plus MMF, 8% received cyclophosphamide. Azathioprine and calcineurin inhibitors were prescribed in lower frequency. Rituximab was used in 5% of the cases, and eculizumab was used in 9%. During a median follow-up of 46 months, 40% reached end-stage kidney disease, and the main determinants of this outcome were having a lower eGFR at baseline, the degree of glomerulosclerosis and interstitial fibrosis and tubular atrophy at baseline, and treatment different than corticosteroids plus MMF. On the other hand, 46% reached any degree of remission, and the main predictors of this outcome was a younger age at diagnosis, a lower proteinuria, and being treated with corticosteroids plus MMF. These figures show the kidney survival curves according to therapeutic regimens, and as shown, kidney survival was significantly better in those patients treated with corticosteroids plus MMF as compared to the rest of regimens. However, considering the retrospective nature of this study, these results could be subject to bias by indication. For example, patients who were treated with corticosteroids plus MMF had a better baseline kidney function and lower chronicity, and thus, in order to prevent or to overcome this limitation, we further perform a propensity score matching analysis adjusting for the main predictors, which were the baseline kidney function, the degree of chronicity in kidney biopsy, and the degree of proteinuria at baseline. This way, 34 patients treated with corticosteroids plus MMF were compared with 34 subjects with similar characteristics treated with another immunosuppressive regimen. Despite this, patients treated with corticosteroids plus MMF continue to show a significantly higher survival rate as compared to the rest of patients. We further analyzed kidney survival according to the presence of pathogenic variants in complement genes or antibodies against complement components, and as shown in both cases, the therapeutic regimen based on corticosteroids plus MMF show a superiority as compared to other therapies. Thus, according to our results, the therapeutic regimen based on corticosteroids plus MMF may be beneficial in all cases of C3G independently of the pathogenic driver being genetic or acquired. And as this editorial states, it is probable that in the future it could make sense to use conventional immunosuppression in addition to specific complement blockers for the treatment of C3G, given the non-specific anti-inflammatory properties of these therapies. So the second paper that we have already published was entitled Validation of a Histology Scoring Index in C3 Glomerulopathy. And the main aim of this study was to evaluate the reproducibility of the C3G histologic index previously proposed by the Columbia University and to analyze its prognostic value. So kidney biopsies were analyzed according to this index with the parameters shown in this slide. So we first evaluated the potential nonlinear relationship between the hazard ratio of kidney failure and the total activity in chronicity scores. And as shown in this slide, we found that the curves became steeper from a total activity score from 9 and became steeper from a total chronicity score about 4. So we confirm that this follow a nonlinear relationship with the hazard ratio of kidney failure. So we developed 3 multivariable models to study the prognostic value of both the individual histological variables and the total renal biopsy activity and chronicity score. In the first clinical model, as shown in this slide, the results were similar to that presented in the clinical JOVSEN study. And as expected, the best prognostic histological determinants of outcomes were the degree of interstitial fibrosis and tubular atrophy, as shown in this slide. And when we, in a third model, we included only the total activity score and the total chronicity score, only the total chronicity score above 4 emerged as an independent predictor of outcome, and conversely, the total activity score did not reach statistical significance in this model. In this slide, kidney survival curves are displayed by the threshold value of total activity score as under or above 9. And as you can see, no significant differences were observed. And in this slide, we show the Kaplan-Meier curves according to the proposed threshold of total chronicity score. As you can see, kidney survival was significantly lower in patients with a total chronicity score above 4. And so as a conclusion for this study, we validated the prognostic performance of the C3G histologic index in our cohort, and the total chronicity score emerged as the main histologic determinant of the development of kidney failure. So this is my last slide of the presentation. And so to conclude, C3G is a highly heterogeneous disease. It is associated with dismal outcomes in a significant number of patients. As seen in this presentation, the main prognostic determinants of outcomes were kidney function and proteinuria at baseline, together with the degree of chronicity in kidney biopsy. We believe that increased knowledge of the pathogenic basis of the disease will help in the development of new drugs against specific therapeutic targets. And we have high expectations with newer proximal blockers, complement blockers, that right now are under investigation. But for now, our results support the use of corticosteroids plus MMF as an effective immunosuppressive therapy for this disease. So this is all. Thank you very much. And right now I'll be happy to answer any question you may have. Thank you very much.
Thank you, Fernando. That was an excellent summary. So we've had quite a few questions on the chat, which is great. So maybe going to start off, if you don't mind, asking you, so you talked about the incidence of C3 glomerulonephritis, but Tejas Patel is wondering what percentage of kidney biopsies would demonstrate C3 glomerulopathy. Do you have any idea about that?
Could you please repeat, because I didn't
catch it? Sure.
Question.
So
yeah.
You talked about the incidence of C3 glomerulopathy,
yeah.
but we've got a question from Dr. Patel asking about the percentage of biopsies which would demonstrate C3 glomerulopathy. So the burden of disease, do you have any idea about that?
Well, we have, it's very difficult actually in clinical settings to have a real incidence of the disease. The big problem we can discuss about it is that probably the current definition of C3 may lead to some confusion in some clinical scenarios. And currently this definition is based on the immunofluorescence staining, and this may lead to some confusion in some clinical scenarios, especially not when the deposits of C3 are exclusive, but when there are 2 orders of magnitude. So this may be a real big challenge, and we can discuss about it, that in the near future is probable that we will need another type of classification to better diagnose this disease, based not only on the kidney biopsy and the immunofluorescence, but in several other probably biomarkers or serum markers of the disease or some other pathological features.
Yeah, so let's bring Elena and Anuja into the conversation, 2 of our panelists. So I think that complement often, I think, causes a bit of confusion with C3 glomerulopathy, particularly whether or not we're basing the diagnosis on genetics, so if there's an abnormality in the genetics, or whether we're basing it on the histology. So Anuja, perhaps you could maybe step in here, and what do you think about how we interpret the complement gene variants in C3 glomerulopathy?
Yeah, that's a very valid question, and a challenge that we have in the field, that when we do genetic testing on these patients, first of all, in C3G, I want to say roughly about 30% of patients, we will find a genetic variant. A lot of the times we find acquired factors like C3 nephritic factor or other nephritic factors. So when a genetic variant is identified in these patients, the genetic labs typically use the guidelines that are set out by the American College of Medical Genetics to report what these variants mean. And based on those guidelines, the variants could be called pathogenic, likely pathogenic, VUS, which is a variant of uncertain significance, benign or likely benign. So it's in one of those 5 levels. Now, when a variant gets identified, and if it's a pathogenic or a likely pathogenic variant, I think most times it is more clear that that is a deleterious variant and may be associated with disease. I think the challenge as physicians or clinicians where we face is that when a variant gets identified and it's a variant of uncertain significance, then we don't know what to make of that. And so I think a few different things can be done and are being done in those cases. One, you could have complement biomarkers that certain labs do to see what is the level of complement activation going on in the patient. Number 2, something that we do personally in a research lab at Washington University is on a research level, we actually recombinantly make these variants, and we do functional testing to figure out if that variant is deleterious. And in many of my patients in my cohort at Washington University, I have about 20 C3G patients pre and post transplant, where we use that kind of data to figure out whether we should treat them and whether we think that variant is deleterious. So even though it's a challenge globally, and I think an issue we face, at least in our level, that's how we are able to interpret some of this variant data.
Okay, so if we're thinking about how we diagnose C3 glomerulopathy, do you think it's fair to say it's a combination of the pathology on biopsy as well as what you find in terms of complement abnormalities?
Definitely. I think it's the biopsy, see, it's a biopsy diagnosis, histologically, what you're seeing under the microscope, genetically and acquired factors, and, complement biomarkers that are being done. So it's a combination of all of that. Yes.
Okay, and just one more question for you, if you don't mind. So C3 nephritic factor. So there's two issues. The first is that the detection assay is not standardized. So I'm going to ask you to comment on that. And the second question from Richard Glassock actually is whether, do we think C3 nephritic factor is just an innocent bystander, or do we think it's pathological? Do we think it causes the problem?
Right. So yeah, I think, again, very interesting and important points. So C3 nephritic factor is the most common nephritic factor that we find in these, but there are reported cases of C4 nephritic factor, C5 nephritic factor that are found. So the first issue, as you pointed out, Kate, was the standardization. So first of all, because there are different assays on how these are detected, there could be binding assays which show that there is presence. So these, first of all, let me go take a step back. A nephritic factor is basically an autoantibody, right? That a person produces that stabilizes the C3 convertase. That's when it's called a C3 nephritic factor. If it stabilizes the C5 convertase, it's a C5 nephritic factor. And if it stabilizes the C3 convertase of the classical pathway, it's a C4 nephritic factor. So it's an autoantibody that the human produces. Now, the question is, if you do a test and it shows binding, it shows that there is presence of this autoantibody, we don't know for sure whether it's just presence or is it functionally active. So when I talked about standardization, it was looking at whether there is presence of the nephritic factor. Is it functional? And I think we need functional testing to figure out, what is it actively doing? There are some data to show that these antibodies will prevent the decay of the convertase. They will prevent the function of the regulators, the factor H, CR1, C4 binding protein regulators. If that is demonstrated, that these are actually functional autoantibodies, I think then you have more confidence in saying that it is involved in the pathogenesis, versus just the presence of the nephritic factor by itself may not be enough to say that this is involved or not. And so there are hemolytic assays, there are functional assays, there are binding assays, and I think what is needed across the board is having more functional assays, more standardization of how the testing for these nephritic factors is done. And I think that'll help figure out whether they are involved in the pathogenesis or not.
Thank you, that's really helpful. So we're having lots of questions about management and recurrence. I'm going to come to them in a second, but just sticking with complement for the minute. So Elena, can I perhaps bring you into this? And could you maybe talk a little bit about how you interpret the pathogenicity of the complement gene variants in C3 glomerulopathy patients?
This is actually a very tricky task to do, because as Anuja was mentioning before, we really are facing a disease which is complex. So we need to take into account all the genetic background, plus the acquired factors and the environmental factors as well. So all this interplay is gonna basically tell us what's the susceptibility of a particular individual to develop this disease. So in terms of how we interpret the genetic variations, I think in C3 glomerulopathy is very difficult, because we are facing different mechanisms of complement dysregulation under the term of C3 glomerulopathy. So in contrast to atypical hemolytic uremic syndrome, where we can see that although we have different genes involved in the disease, they all lead to one single pathogenic mechanism where complement is causing damage on the endothelium. In the case of C3G, we are having some mechanisms where we have fluid phase massive dysregulation in the case, for instance, of the factor H deficiencies, but we are also facing dysregulation that does not affect the regulation of complement in the fluid phase, but just locally, maybe in certain surfaces, as might be the GBM or the mesangium. as is the case, for instance, of the factor H-related proteins, type of mutations associated with C3G. So I think for us, when it comes to interpret the genetic variation that we find in the patients, we really need to be careful about, first of all, what's the gene where this mutation is sitting? Is it a complement regulator? Therefore, if it's a complement regulator, we can explain the pathogenicity if we are identifying a deficiency of the protein, but or a defect in the function of the protein. But for instance, if we identify the rare variation in a complement component that participates in the activation, like C3 factor B, then we are looking for rare variants that cause a gain of function of this protein. So, for instance, if we find a deleterious variant that causes the deficiency of the protein, that I think is more tricky to understand how this variant can lead to or can contribute to the pathogenesis. So we are looking for gain of function type of mutations. And also, so I think it's really difficult how we interpret this data. And I agree with Anuja that really we need to do functional testing to really understand the contribution of that rare variant. Without that, we are missing a lot of information. So at the moment, we have been classifying, or the different labs have been classifying the genetic variations into likely pathogenic or benign, also according to the frequency of this type of variation in the normal population. But in fact, now we know that the control population is not that rare to identify a rare mutation in any complement gene. So when it comes to make a diagnosis and to reinterpret in one patient whether the variant is pathogenic or not, just by the frequency is not a very good tool to validate whether it's pathogenic or not. So we need these functional assays, that's for sure. And for some genes, it's easy, like factor H, but for others, it's more complicated, like the factor H-related proteins, for instance, that we don't know what they do, what's the biological role. So,
yeah, and it's also difficult depending on which country you're in and where you are in a country to get access to these types of genetic tests. So it's pretty challenging all in, I would say. So let's think for a second about the histology. So the histological diagnosis can be pretty challenging. There's underdiagnosis, overdiagnosis. There's what we think about C3 staining appearing in somebody who we don't think has got C3 glomerulopathy and what the significance of that is. So I'm maybe going to bring in Prof. Prado, so Manolo. I wonder if you'd like to say anything about histological challenges in diagnosing C3G. Oh.
I think that we need more information, particularly in patients with histological patterns different from membranoproliferative glomerulonephritis, you know, because in my experience, I have some patients have been referred to our department with erroneous diagnosis of C3G, particularly patients, for instance, with focal segmental glomerulosclerosis or other histological patterns with C3 deposition. I think that it's important to consider that the diagnosis of C3G requires a diffuse, intense deposits of C3 and the presence of deposits on electron microscopy. So I think, yes, that the histology is very important for the definition, as Fernando explained. But you know that approximately 75% of the patients having a pattern of membranoproliferative glomerulonephritis, but there are other patterns, and I think that we need more information to analyze carefully if these patients are true C3G or they are examples of overdiagnosis. I have several examples of overdiagnosis in my clinical experience, you know. And on the other hand, this is a new entity. So there is also a underdiagnosis, no? The patients who go to dialysis and renal transplantations with other diagnoses, and then the post-transplant evolution show that they have a recurrence of C3, or in some rare cases, presentation with TMA, thrombotic microangiopathy. This is another curious phenomenon.
Okay, and have you seen C3 staining then by IF, but no proliferative lesions by light microscopy and no deposits on electron microscopy?
Sorry, could you repeat the question?
Yeah, of course. So would it be fair to say then that from what you're saying in terms of over and underdiagnosis, have you seen cases where there's C3 staining by IF, so immunofluorescence, but when you look at light microscopy, there aren't proliferative lesions and you don't see deposits on electron microscopy?
Yeah. Obviously, there are very. I have seen patients with non-membranoproliferative patterns with a diffuse C3 deposition, and these are difficult cases. In my opinion, they need a deep investigation about genetic variants, the presence of C3 nephritic factor, etc. But I think that the combination of light microscopy, immunofluorescence, and electron deposits in most of the cases lead to the right diagnosis. But on the other hand, another very important point, in my opinion, is the transition from acute post-infectious glomerulonephritis to C3. You know that there are several series of patients with acute post-streptococcal glomerulonephritis with no resolution of hematuria, proteinuria after several months, and in a second biopsy, a diagnosis of membranoproliferative C3 has been established. These patients are very interesting because in many of them, variants in complement genes, the presence of C3nef and other autoantibodies has been discovered. But you know that the borderline between immunocomplex membranoproliferative glomerulonephritis and C3 is not so clear. You know, there are some cases with changes from immunocomplex membranoproliferative glomerulonephritis to C3 and vice versa. So I think that we need more information. Perhaps infections can have an important role in this change from immunocomplexes observed in some biopsies that then disappear in another biopsy. I don't know. I would like to know the opinion of Elena and Anuja about the role of infections of this disease, particularly in patients with no clear genetic abnormalities, the role of infections.
Yeah, so can we throw that open actually to Anuja and Elena and Molly as well? Perhaps Anuja, you could comment first of all.
Yeah, so yeah, I think that's a very, very important point that we need to remember. The post-infectious GN, there are cases I think that can be C3G, and I think important to remember that in post-infectious cases, those patients that do not recover, that do not have resolution like you would expect in a post-infectious case, that remain hypocomplementemic, that continue to have proteinuria and continue to have a more aggressive course, are the patients that should be tested to make sure that these are not C3Gs and that they don't have an underlying genetic or acquired etiology, number one. Number two, the issue about the immune complex gene and the C3G, that is also extremely important. There is some thought that it is possible that there is an infectious trigger that starts out the classical pathway activation. So there is an immune complex that the patient has because of the infection that activates the classical pathway. But then that whole burden shifts to the alternative pathway. So there can be start of a trigger from infection because of classical, but if the patient has a defect either a genetic or an acquired, and that whole thing shifts to now the alternative pathway keeps going. Remember, the alternative pathway has that feedback loop. So no matter how the trigger starts, if the patient has an underlying defect, it can go into the alternative pathway and the patient can keep going, and that can actually turn out into a C3G or a C3GN. So there are cases of immune complex which were called immune complex GN that have genetic abnormality because there was an infectious trigger. It started out with an immune complex process. And that is also the reason why under histology, it is not only, when they're looking at histology, the definition is not C3 deposition by itself. You can have immune complexes with C3, with C3 being 2 orders of magnitude higher, knowing that these immune complexes may have triggered and then moved over to the alternative pathway. Is that making sense?
Yeah, that's perfect. Thank you for that. Elena, do you have anything you'd like to add about the role of infection in C3 glomerulopathy?
Yeah, I mean, I totally agree with Manolo's and with Anuja's comments. And actually, it's interesting because when you look to the genetic or acquired factors in either immune complex MPGN or C3G, they are very similar. And so therefore, it doesn't matter, as has been said, maybe the infection and the activation of the classical pathway is just the trigger, but then an underlying genetic defect in maybe affecting the alternative pathway then gets into the equation and participates in making this resolution of inflammation a problem and therefore developing C3G. And also, yes, I am also aware about the same patient that has gone through different biopsies. Sometimes it shows an immune complex and PGN, and then the next one is a C3G or the other way around. So again, that's why my concern about whether in terms of complement dysregulation is good when we make all this classification type of classification, and maybe we should look more into the specific mechanisms that may be an overlapping feature between many different type of diseases, which they all have in common this C3 deposition, but then there would be an overlap of various factors, either genetic or acquired, all across these different entities. So yes, it's very complex, I'm afraid.
Yeah, it's very complex. Prof. Molly, I think you're here now. Do you have anything to add in terms of what you think about the role infection has to play? Oh. Okay, so let me Fernando, you've had a little break, so let me ask you a question if you don't mind. Yeah. In terms of the biopsy, do you think there is a role for C4D staining in the differential diagnosis of C3 glomerulopathy?
Yeah, well, there have been different studies using C4D, which in some cases they can help this staining to distinguish between the immune complex deposition versus the only implication of the alternative complement pathway. In this respect, I would also like to point out that the immunofluorescence staining used in clinical settings actually stains for C3C, and the predominant fragment used that has been shown in C3G is the fragment C3D. So maybe the question is not only should we use C4D in some cases, but should we move toward C3D staining for the better diagnosis?
Okay. And then, so I'm being a little bit unkind. One more biopsy question, if you don't mind. What about pronase digestion? Do you think we should be using that more?
Well, the big problem in pronase, well, as some pathologists says, is that it's a difficult technique. So it's probably not to be used as a routine method, but in some cases it may be interesting, especially when there is an underlying monoclonal gammopathy, because that's the big problem. Is that monoclonal gammopathy playing any role in the disease or not? Because that has an important therapeutic implication. We can talk later about this. The important therapeutic implication of whether the monoclonal gammopathy is playing any role in the disease and the complement dysregulation.
Well, since you've brought it up, why don't we just talk about that now then? So, I mean, absolutely right. So monoclonal gammopathy in C3G, when does that become a monoclonal gammopathy of renal significance? And it can often be quite difficult, can't it, to engage with the hematologists and convince them that this is something we think is significant. So I'm going to just jump from you to Anuja and ask Anuja what she thinks about this and the relevance of it in C3G and when we should be treating it.
Yeah, so this underlying monoclonal gammopathy and the association with C3G now, I think, has been fairly well published, especially in patients who are over 50 years of age. And that's where we see a lot of these cases. And I would agree that doing pronase digestion, at least in those cases, is important. I have personally faced issues where I had a patient who was, I think she was 68 years of age, and she had monoclonal gammopathy, had C3G diagnosed. This was C3GN in her biopsy. She had a variant in factor VIII. She had a C3 nephritic factor and a factor VIII autoantibody. So can you imagine the realm of everything that was going on? And her level of monoclonal protein and her bone marrow biopsy did not qualify her for being a frank myeloma disease. And I think we really ran into trouble with hematology agreeing to treat a patient like this, because in our opinion, this was not a monoclonal gammopathy of unclear significance. It was clearly of renal significance. So they agreed to treat her. This was pre-transplant. They agreed to treat her. We did a kidney transplant in this patient. Her monoclonal gammopathy came back after transplant. That coincided beautifully with the recurrence of C3G in this patient. And she had to be treated again afterwards. Unfortunately, she died for some other reasons. But I think that we have to push this point forward, that even though they don't meet the criteria for a frank hematological malignancy, when we see patients with low levels and you see a kidney disease, we need to push for treatment.
Thank you.
Sorry, an important point regarding C3G related with monoclonal gammopathies is about the treatment, because there is a general tendency to consider hematologic treatments in these cases, and perhaps anti-complement therapies, including, why not, corticosteroids and MMF, could be also effective. It's important to consider that the anti-myeloma treatments, the hematological treatments, many of them have very, very important side effects. So I have the experience, but in some cases, with good efficacy of less aggressive treatments in these cases. For instance, you know that monoclonal gammopathies can also induce hemolytic uremic syndrome, and I have seen patients with a rapid resolution with Eculizumab in patients with monoclonal gammopathies. I mean that not always is needed to put these patients in anti-myeloma treatment, you know. Although I think that the information we have is still preliminary and we need more information.
Another, I would like just to point out one more thing, is that probably it's our time, given the difficulties with the hemato-oncologists, maybe it's our time to start treating with bortezomib without their permission.
Okay, Anuja, bortezomib without the hematologist permission? Any thoughts?
I don't know about that. I would want to probably rope them into a collaboration and maybe make sure that they're on board with us. I think it's more about a collaborative effort with Hemonc. I think they need to get on board with this issue. I would feel uncomfortable taking over.
Yeah, so let's keep them on side, I think, is the message there. Okay, so let's talk a bit about treatment, because we've had lots of questions about treatment. So maybe I can come back to you, Manuel, about the treatment of C3. So I guess perhaps it would be helpful just to think about, so if we're using mycophenolate and steroid, how long do we use it for? What do we do if somebody relapses? Then how long do we treat for after a relapse? What could predict relapse? So I guess that's a starter for 10.
Yeah, in our paper in Clinical JOVSEN, one of the most important factors predicting relapse after remission with MMF was the duration of the treatment with MMF. So perhaps in aggressive cases with a good response to corticosteroids and MMF, I think that the most practical and best way is to maintain MMF. Why not without interruption? Because we have seen several patients with clear MMF dependent patients, you know, and MMF, you know, that this is in general a well-tolerated immunosuppressant. So while waiting for more specific therapies for this disease, I think that in very aggressive cases, with a good response to this combination of corticosteroids and MMF, the discontinuation of the treatment should be very careful, and with starting again the treatment in case of relapse.
Okay, and would you use...
Fernando, any comment on? No?
Yeah,
I
actually,
don't know.
in our...
Yeah,
actually...
Yeah. The amount of proteinuria at the time of MMF discontinuation didn't have any influence on the relapse, or?
Well, actually, our study is subject to some limitation, as acknowledged in the paper, and we found that almost 1/3 of patients experience a relapse in a median of 26 months after its discontinuation. We found that a better kidney function and younger age at diagnosis were associated with this relapse. And as Manolo said, in the multivariate analysis, the shorter length of treatment with corticosteroids plus MMF increased the possibility of this relapse. But we should test this further in prospective trials. I would like to just point out that we are also working on the potential use of some surrogate markers to test the effectiveness of newer therapies. We are working on the potential use of proteinuria as a surrogate marker for outcomes, especially for the development of kidney failure. And why not? It may be also a good marker to decide whether specific treatment should be stopped, or considering the whole patient and the individual cases.
So do you think, Fernando, then that using aspects of the complement system, we could use them to monitor the disease? So C5b9, for example, do you think that should be used routinely and would give us some information about the disease and whether?
Well, in our clinical practice, we don't have the possibility of testing continuously C5b9. We only have C3 or C4. And Justin, Dr. Elena Goicoechea has the opportunity to test C5b9, and we don't have experience on that, but it is probably that using any type of serum biomarkers could be helpful in this respect. I don't know if Elena has anything.
Yeah, so Elena, could you comment on that?
Yeah, well, the only thing is not, so the increase in soluble C5b9, it doesn't apply to all the patients. So again, this resembles the heterogeneity of the patients. And for some of them, it might be a good marker if it's increased, and therefore it should be decreased if there is a response. But as a general, let's say, biomarker for C3G patients, I don't think it's going to be good enough. And also it's got some complexities in terms of how sensible this measurement is according to how the samples have been manipulated. So I guess it's not the best biomarker, I would say.
Okay. So there's lots of questions about transplant. I'm going to come to Anuja in a wee second, but can I just bring Prof. Molly in? I think I was a little bit quick to the last time you hadn't unmuted. Hello.
Hello. I can just add something to Elena. So soluble C5b9 was not correlate with the activity of the disease on the biopsy. So I agree with her that it's difficult to use it as a good biomarker. But probably the staining, the C5b9 staining, it's probably better biomarker than in the fluid phase.
So I guess two practical questions. The first is, so for things like ANCA vasculitis, we can say to patients, expect to be on this treatment for at least 18 months. So for C3 glomerulopathy, is there a sort of time period that you would suggest that people stay on the MMF and steroids before you start to wean? Or would you just see how things go, how things progress? Perhaps Fernando, you could answer that.
Well, I think in C3 glomerulopathy, it is important to personalize treatment considering the high heterogeneity of the disease. There are some cases in which a response is seen earlier in the course of at the initiation of treatment, and in some other cases, the results are not shown until some months have already passed. So in this respect, as I said before, we need some surrogate markers to better define whether, and especially in the coming years when we will have these complement blockers, we will need some surrogate markers to know whether we are doing the correct decision in terms of the therapeutic alternatives available.
Yeah.
Okay.
I think that it's also important to comment that there are benign cases. No, there are cases with mild proteinuria and stable normal renal function, and the consensus is to treat these patients only with supportive care. So I think that this is an important consideration. And on the other hand, we are supporters of corticosteroids and MMF, but a good example of the limitation of this treatment is that recurrence after renal transplantation is very high, with a serious prognosis in patients who are receiving corticosteroids and MMF to avoid rejection. So obviously the patients who receive a kidney transplants are the more severe cases. But I think that our hypothesis is that corticosteroids and MMF are non-specific treatments, probably acting through their anti-inflammatory properties, anti-fibrotic properties, but they are effective, but they have many limitations, and the scenario after renal transplantation needs more investigation and more specific therapies, in my opinion.
Yeah, I think that's true, and it's brilliant. There are lots of questions. I'm sorry we're not going to be able to answer them all, but let's try and get through a few more. So what about other treatments? So before we come to transplant, what about in somebody who's got disease with crescents, for example, in biopsy? Would you plasma exchange them? When would you reach for Eculizumab? Would you use rituximab? So open to anybody.
Well, I think Dr. Mogli-Lecantre,
yes.
She has a lot of experience about.
Okay, over to you first then.
I fully agree with Manuel. So it's probably different disease in native kidney and renal transplantation. And in renal transplantation, the clinical recurrence, it's more aggressive disease. So when we need to have other treatment, because we know that this patient had already immunosuppressive treatment. So in our experience, we treat a patient with Eculizumab when after renal transplantation there is an acute renal failure. associated with C5b9 on the staining. And in this case, it works well. We haven't published our data, but it works well in this case, in 50% of the case. So for the other patient, it's probably another mechanism, or perhaps more with the necessity of the C3 pathway engagement than C4 pathway. But we notice that if you don't have C5b9 on biopsy after recurrence, the Eculizumab didn't work in this. So it's probably a biomarker after renal transplantation, but the disease is very different from the native kidney. Yeah. It's more aggressive because the patient had already immunosuppressive treatment, so they have a recurrence on immunosuppressive treatment. So we know that 50% of these patients had a recurrence after renal transplantation. Only 50%. So that means that in 50% of the patient, immunosuppressive treatment allowed not to have this recurrence. And the second thing, very important, it's that after renal transplantation, you can just have deposits without any clinical marker, proteinuria or inflammatory lesion on the biopsy. In this case, it's probably not necessary. There is not necessary to treat, because the prognosis is probably not so different than patient who had no deposit without any inflammatory lesion. So just important to follow this patient. Before that, I just one note that we can see the C3 deposit in a routine biopsy that we practice in M3 or 1 year after renal transplantation. So it's, in this case, it's not necessary to treat only C3 deposit without anything. But if there is proteinuria or inflammatory lesion associated with acute renal failure, I think we have to use to block the complement. Yeah.
So I'm just going to ask a couple more questions. So am I right in thinking that what you're saying is you wouldn't use Eculizumab in native disease? Is that a fair comment?
Yes, we use it when the patient had acute renal failure after renal transplantation, okay, due to the recurrence. And on the biopsy, there is, if we are just recurrence, but not other lesion of humoral rejection, ABMR or cellular rejection, it's yes, this treatment probably currently it's the best treatment, because we have an other blocker of the complement. If the rituximab or for C3nef, we know now that it doesn't work. Even this is not the good treatment. So yeah,
so we wouldn't use it. Yeah. And Ija, what's your experience in transplantation?
Yeah, so I agree with almost everything that's been said. I agree that plasmapheresis and rituximab, for reasons we don't understand, doesn't work. Because if you think about it, for patients who are carrying a nephritic factor, if it's an autoantibody, why don't they behave the same like any other donor-specific antibody? But for some reason, even in my experience, I have young patients who harbor these autoantibodies, that those antibodies don't seem to go away with pheresis and rituximab. So it seems to not work. And number two, I also agree with the fact about the soluble C5b through 9 that has been said. I think there are very few patients with C3G who will respond to Eculizumab. I saw a question about when you would reach for it. And from what I've known in the literature, you know, if if there is evidence of terminal complement activation, if there is evidence that there is C5b9 deposition going on, maybe it's useful in those patients, but a lot of the activation in C3G patients happens upstream to that pathway, and a lot of it is already happening at the level of the C3. So Eculizumab doesn't work in those patients. So really, I think what's needed post-transplant is the newer inhibitors that are being in development. There is a factor D inhibitor, a factor B inhibitor, a C3 drug. Most of these are coming out. And I think that is a very, I think that's an interesting field that we'd be looking at. But one of the things we'll be still, I think, facing would be, it'll be important to understand the etiology in a patient and direct therapy. So if you know there is a C3 nephritic factor and it's functional, and then you can direct that whether you should give that patient a factor D inhibitor or a factor B inhibitor. I think it's important to understand the etiology in patient and then direct that particular therapy to each patient. And
so individualized therapy, and you've kind
absolutely, that's what this
you kind of walked into this, I guess. So one of the problems that we have is that complement studies take an awful long time to come back sometimes. So how do you handle that when you're trying to make therapeutic decisions like the ones you're talking about?
Yeah, so that's an interesting thing. Now, TMA, aHUS is different from C3G. TMA is more of an acute, sudden onset thing that happens in a lot of our patients post-transplant. And so in those patients, you go ahead and treat and you wait for all these studies to come back. If you're suspecting complement-mediated TMA, that's a separate story. C3G, thankfully, is a slightly slower progressive disease. So in most of my patients, it's happened in like 3, 4, 6 months when the recurrences happen. That's the earliest I have seen. I have patients who've recurred after even 4 or 5 years. But so I think in some of these patients, we have a little more time to understand what is going on compared to an aHUS or a TMA case where you have to make a decision right away within 24 hours. So that's my experience in these cases, that for C3Gs, I think you have more time to investigate and evaluate and put pieces of the puzzle together.
Yeah, just a comment. I think a fascinating type of patients are C3G with coexisting TMA. These are very rare. We have seen a patient with a recurrence of C3 after renal transplantation with peripheral signs of microangiopathic hemolytic anemia. And the patient responded well to Eculizumab. So probably in this type of patients with coexisting TMA, Eculizumab could be a good treatment, no? But I don't know studies looking carefully for lesions of TMA in patients with C3G. Some nephropathologists has told me that they are more common than suspected. I don't know if you have some experience about this coexistence, no?
Yes, I fully agree with you, Manuel. There is after renal transplantation, some of patients with C3G or native kidney had a TMA in the recurrent. So there is an overlap between this both disease, and probably because after renal transplantation, the endothelial cells are more vulnerable. So as it's the mechanism could be very close. We can see in our cases series of 60 patients, 10 patients had TMA after renal transplantation and biopsy. So it's not so rare. Yeah. And some of cases as a report too of patients with C3 native kidney and after renal transplantation, they had a recurrence and their TMA after. It's not the most common, but yes, we can see that. Yeah.
Elena, do you agree with all of that?
Yeah, absolutely. I mean, and also, but we shouldn't forget that the transplant itself is a risk factor for TMA. So yes. I guess, of course, if there is also an underlying genetic defect that might show that there is a problem with the dysregulation of the alternative pathway, if you add the transplant itself, then you are triggering somehow TMA. That's, I guess, it's rare, but not that rare. because of this, yeah.
Okay, so one last question, Fernando, I'm going to give this to you. So what about the role of renin-angiotensin aldosterone blockades or things like direct renin inhibitors like allosterone? Do they have a role, do you think?
Yeah, well, there's only, as far as I know, there's only one paper that analyzed this, and that's the Swedish group, if I'm not wrong. And they found that the renin had the ability to cleave the C3 into C3b and C3a in a manner similar to that of C3 convertase, and this cleavage was blocked by aliskiren. These results were tested in 3 patients with dense deposit disease, and they showed a decreased systemic and renal complement activation, as they say, over a period of 4 to 7 years. Since that, we haven't had more information, and in our clinical practice, we don't use, in general, aliskiren. These results are very provocative, but we don't have that experience. So it is probable that in the near future, if these results are confirmed in a larger cohort, it is probable that we should avoid using the conventional RAS blockade. I don't know whether the rest of the panelists have any experience on using aliskiren in this kind of patients or not using RAS blockade. Actually, in our retrospective cohort, most of the patients were treated with RAS blockade, so we didn't have any possibility of analyzing the potential deleterious effect of these therapies as compared to other direct renin inhibitors.
Okay, so final thoughts from the rest of the panel. Allosterone, yes or no? Molly? Oh, you're on mute. Nope. Let me unmute you. What about Anuja?
Yeah, I have not personally reached out for it myself. You know, I've gone with my regular ACE ARBs for proteinuria. Okay. And so I can't comment that it's more beneficial than the traditional therapy right now.
Okay. Amelia, I think you're unmuted now.
Yes.
Yeah.
Yes, I agree. In patients with proteinuria lower than 1 gram per gram, I think it could be a good therapy in patients who had no so aggressive disease. But for the other with nephrotic syndrome or immunosuppressive treatment, looks to be the main treatment. Yeah.
Yeah. And Manolo? Oh, you're on mute.
Yeah. No, as Fernando said, there is only one paper about this important question, because it's not only, as the paper showed, that aliskiren could be effective, could be beneficial. The problem is that, according with the data of this paper, ACE inhibitors and ARBs could be deleterious. So this was a provocative study, but there were only 3 patients, no, Fernando, included in this paper. Yeah. And as far as I know, no other studies have addressed this important question. I would be really surprised if these data are confirmed, because it would suppose to prohibit renin-angiotensin blockers in these patients. So we must wait for other studies about this question, in my opinion.
Okay, agreed. So Elena, complement C3GN is your thing. Is there anything else you'd like to say just to wrap it up? You get the final comment.
Oh, I get a final comment. Well, I mean, this is a story about other proteins, not the conventional proteins, to activate complement. It seems to get more and more, they are in fashion now, because there have been some papers out recently also showing other ways of bypassing either C3 activation or C5 activation to activate the complement system, as like I think it was a couple of weeks ago, there is a very nice paper of Christoph Smith from Germany showing how you can actually bypass the you can activate C5 without even having a C3 or C5 convertase. So this is being extremely challenging. So I guess there are multiple mechanisms how complement might be dysregulated. So to even add an extra layer of complexity to this
The whole story.
disease. Yeah.
Okay.
It's going to be very interesting in the next years, actually.
Yeah, absolutely. So Fernando, that was a terrific presentation, and our panelists, that was absolutely brilliant. So we had loads of questions, loads of interest, lots of people on. So thank you very, very much to you all, and enjoy the rest of your Sunday.
Thank
Take
you.
care.
Thank you, Kate.
Bye.
Thank you, guys all.
Bye.
Bye.
Thank you, everyone, for joining. See you next week.
Bye, dear.
Thank you.
Bye.